If you don't have centric relation, you'll have grinding, you'll have TMD, you will destroy your crowns, and you will not be stable. How many times have you heard this story? How many times have you seen this occlusal war from different occlusal schools saying you are sick because you are not in our position? So which centric relation gives you stability? Those of you who've been around for a while knows that the definition of centric relation has changed over the years 26 times. And I will show you how the latest definition was developed. So we do not have controversies about the position of the teeth. Nobody wants to have a unilateral open bite. But if it comes to the position of the condyle, this is probably the biggest controversy in the dentistry so far. So we will not be talking only about the centric relation. We will be talking about 5 different condyle positions and their controversies. So we'll figure out if you always have to go from the MIP to the centric occlusion. Do we always have to push our patient to the position that we think is better for him? We will wonder, we'll talk about relaxation of the muscles. When should we go for myorelaxation and the neuromuscular dentistry? We will also talk about the centric slide, because you probably know that in 1957 Posselt said that 90% of population have a centric slide. So from the centric relation, the old definition, to the maximum intercuspation. And at that time we came up with conclusion that 90% of population are sick people and only 10% are healthy. Where is the logic in here? Has the nature failed to develop healthy masticatory system for majority of us? So we'll talk about different positions. Should we really put our patient into the rearmost position, or maybe better position will be the uppermost, or maybe we'll move our patient a little bit more forward? We will also talk about the 4-7 position, famous radiological position 4-7. And you know, we the dentists, we really like to confirm position of the condyle with the x-rays, with the 2D pictures, with 3D pictures, like in here on the CBCT. Some people really like to have a symmetry in the fossa. Some people are using some special formulas to find the best position of the condyle in the fossa. So we'll think about, do we really have to do that? Or when do we have to look at the position of the condyle on the CBCT? Because when you look at this condyle, you may think whether it's good position or not. Some of you will say that this is very good stability. Or what about this condyle? This is wrong? Is this position wrong? What about this position? Is it distalized too much? Or what about this position? Is it not too much forward? So finally, we'll also discuss about which bite should we choose for our patient if we just have one missing molar without any TMD, without any attrition. Which bite should we use if we have a couple of missing teeth and just a little bit of attrition and maybe some muscular symptoms? Which bite should we use if we have a completely worn down, if the teeth are completely worn down and we are sure that we will have to increase vertical occlusal dimension? So how can we increase vertical occlusal dimension and to get to the centric relation? So we can use different devices that we'll talk about today. We can use some manipulation. We can also use longer deprogrammation or even splint therapy that will be much, much longer. So what we will also talk about will be tricentric relation. And you know, centric relation is very controversial subject, so you probably already know that tricentric relation will be triple controversial, because we do not speak only about the teeth, we also speak about the joint, and we also speak about the cervical vertebrae. So at the end of this 1.5-hour lecture, you'll probably know why sometimes it's better to be roughly right rather than precisely wrong. Ladies and gentlemen, I'm Lucas Lassman, and I can kindly ask you to fasten your seatbelts and prepare for scientific roller coaster in augmented reality. So let's get it started.